So, hello, everybody. This is Adam Gaffney. I am very excited to be joining you for this hour to be delving into Senator Bernie Sanders' single payer bill. We can call this everything you wanted to know about Bernie Sanders' single payer bill, but we're afraid to ask. So, very excited to be doing this. I am a member of the board of PNHP. I'm a pulmonary and critical care doc at Cambridge Health Alliance and Harvard Medical School. I'm happy to be talking about this. Now, I should say that this is a slightly different format than we initially envisioned. Initially, this was going to be a conference call, Q&A, to sort of allow back and forth. But as a result of how much interest there was, we're going to be doing it in this format instead. The upshot of that is that we get to have more people involved. The downside is that you have to hear me sort of blather at you for a whole hour. But I will, in fact, be focusing mostly on the questions that you sent in. So many of you sent in questions. We have a ton of questions. There are actually too many to get to, but Dixon at the national office was kind enough to sort of categorize them into sort of the key questions. And so I'll try to hit as many as I can over the course of the hour. I should also say, in case we want to have a couple questions that are not from the list or that come up over the course of the hour, if you want to tweet at me during this live broadcast at AW Gaffney, I might see that, and maybe we can get to a couple of those questions as well. So let us get started. So I'll talk for about 5 minutes about what Sanders' single payer bill would do. So to begin with, this is a real single payer bill, meaning it is universal. So from the perspective of who would be eligible, it does in fact cover not all citizens, but all residents. So that would really encompass everybody in the country. It is in fact what we would consider universal health care by any standard. Now, moving on, what benefits are covered by the bill? So it covers essentially a very comprehensive spectrum of benefits: inpatient care, outpatient care, preventive care, maternity care, drugs, dental, vision, reproductive care, and I'll get to a little bit about that, more about that in a moment. What it doesn't cover, and we'll talk more about this, is in an explicit fashion, or at least as part of the single payer program, long-term care. Now, unlike in the current system in which you have insurance networks and you have to choose a doctor within your network, and if you go outside of your network, you're in big trouble because you get a huge bill, this would largely be the end of insurance networks and the beginning of one big network. One big network consisting of the overwhelming majority, one can presume, of the nation's physicians. So individuals who participate in this program, which again be the overwhelming majority of people, would be able to choose the doctor that they wanted to see, the hospital that they wanted to see, that they wanted to attend. And so it would be real freedom of choice when it came to healthcare providers. How about from the perspective of cost sharing? Nowadays, in addition to paying a premium, you have to often pay co-payments, deductibles, co-insurance, and so forth. So with one exception, and I'll get more into this in a bit, prescription drugs, the Medicare For All system envisioned, outlined by this bill, would allow no cost sharing. So this would be the end of co-payments and deductibles, again, with the exception of co-pays for certain drugs. There are also, some controls on costs in this system. For instance, importantly, the Medicare For All program would be allowed to negotiate with pharmaceutical companies to bring down drug prices. Another way in which it would control costs, which is critical, is by essentially excluding or prohibiting private health insurance that duplicates basically any service that is covered by the Medicare for All bill. So there might be some private insurance sort of at the periphery for, something like cosmetic surgery, but for the most part, all of the benefits that are covered by the single payer program, which again are comprehensive, could in fact not be covered by private insurance. And the reason why that's so critically important is because a lot of the savings of a single payer, the administrative savings, come from the of waste that is sort of inherent in a fragmented system. And one estimate that of the potential for savings under single payer comes to more than $500 billion a year annually in savings as a result of eliminating the private health insurance system and moving towards single payer. So those are, in broad strokes, some of the things that Bernie Sanders' Medicare for All legislation would accomplish were it enacted. That is, again, the real basics, and that's probably things that everyone has heard of. So what I'm going to do is step back a bit and focus on all of the questions that were sent our way to really get into some of the more nitty-gritty aspects of the bill. So one individual wrote a very simple question, which is, how does this compare to H.R. 676? That H.R. 676 is, of course, Representative John Conyers' bill in the House of Representatives. And it's worth noting, just kind of as a side note, John Conyers' bill now has the support of a majority of Democrats in the House of Representatives, which was a huge milestone that was reached this year, while Bernie Sanders' bill has the support of 16 co-sponsors, which again compares to 0 in previous years. So although the focus today is on the nitty-gritty policy aspects of this bill, it's important to keep in mind what it represents from a political perspective as well. So H.R. 676, and the last thing I'm going to say about H.R. 676 before getting into the side-by-side comparison is that H.R. 676 is very close to the physician's proposal, PNHP's own proposal. So in many ways, by comparing these two bills, the Senate bill and the House bill, we're also comparing it to our proposal, which we published in a revised form last year. So there's several. The way I would compare it is by emphasizing the strengths and weaknesses in each bill. So I'm going to start with a strength in the Sanders bill, at least from my perspective, which is that the Sanders bill explicitly covers reproductive health care and mentions that essentially takes out of the equation the Hyde Amendment when it comes to covering healthcare services. What that would mean is that the Sanders bill really does cover this full spectrum of reproductive healthcare, including abortion, which has not currently the case given the Hyde Amendment, which precludes federal monies being used for abortion in most cases. So I think that is one strength of the Sanders bill that is not mentioned in the Conyers bill. That being said, Conyers himself is very much in support of making available the full spectrum of reproductive health care and actually getting rid of the Hyde Amendment. So that's column 1. What's in column 2? What are some of the advantages from from PNHP's perspective, at least, of H.R. 676 and ways in which the Sanders bill might be improved? There are several. So the first I would say is cost sharing. So we know that cost sharing, which again is money you pay out of pocket when you go to the doctor, fill a prescription, these are co-payments and deductibles. We know that cost sharing deters people from seeking care. We know that it squeezes the wallets of the working class. We know that it has negative health consequences in many instances. And we know that it's unnecessary on the basis of the experience of Canada, where there are no co-pays for doctor's visits, or the experience of the UK. So both bills admirably eliminate co-payments and deductibles. The difference is that the Sanders bill maintains limited cost-sharing co-payments for pharmaceuticals. So in the Sanders bill, certain drugs there could be co-payments for certain drugs. This is done with the purpose of sort of incentivizing the use of generic drugs, and we'll talk more about that in a minute. But preventive drugs are excluded. That's one area of difference. A second area of difference, and it is actually quite important, and it's something that I think we should want to see fixed in Sanders' bill in coming years, and that's what is referred to as global budgeting. And these seem like sort of arcane policy points, but they really do make a big difference when it comes to cost control. So global budgeting means that a hospital gets a lump sum payment for all operating expenses over the course of a given year. What that means is that the hospital does not need to add up the price tag for each patient who comes through. The hospital does not need to compute, or tabulate a tab for each patient. And that reduces the number of billers you need, the number of coders, the number of hospital administrative staff. So global budgets really allow us to reduce healthcare spending in a major way by maximizing our administrative savings of a single payer system. The Conyers bill includes global budgets. The Sanders bill does not explicitly include them, does not mention global budgets. So those are the first two differences I want to point out. A third difference I think is also important, and it relates to the presence in the, or rather the participation in the Medicare for All system of for-profit, corporate, investor-owned healthcare providers. So we're talking about for-profit hospital chains, dialysis chains, nursing home chains, and that sort of thing. And the evidence points to the fact that for-profit providers do an inferior job in many instances of providing quality care. That's been seen for a number of different types of providers. And for this reason, PNHP has for a long time opposed the inclusion or the participation of these providers, and has instead called for them to be converted into nonprofits as part of their participation in the program. So the Conyers bill excludes for-profit providers, whereas the Sanders bill does not make a mention of it. A fourth difference between the bills pertains to the something that's even more arcane from a policy perspective, perhaps, but that makes a difference, and that's separating capital expenditures, which are monies used for things like new hospitals, new plants, new facilities, big new equipment, and operating expenses, which is the month by month, year by year money needed to run a hospital, run a doctor's practice, pay salaries for healthcare workers, and so forth. And this is something that's also in the PNHP proposals, and that we believe is important to control costs, because it's very hard to control costs if you're not controlling how many new hospitals are being built, or how many hospital wings are being built, or how many new proton beam centers are being built. All of these new capital expenditures actually drive up costs down the line. So in Conyers' bill, it's clear that those funding streams are separate, and hospitals can't, for instance, use their profits from operating to build new equipment. They need separate money that's allocated specifically for the purpose of new capital facilities. And the fifth difference, and this question's taking quite a while because it's a big one. The fifth difference is relates to long-term care, and so long-term care is covered in the Conyers bill as any other sort of care is, whereas in the Sanders bill, long-term care is provided instead by Medicaid, which would really continue to exist only as a long-term care provider. Okay, we'll get more into that as we go through some of these other questions. So here's another question from another participant in this event. Why is it essential to include dental and vision coverage? And I think, the easiest way to think of that, because people bring this up often, they say, oh, well, in Canada, they don't actually include dental, so why should we be doing this here? We're making a system that's even more comprehensive than Canada, as if that's a bad thing. You'd think we want to have the best system we possibly can. And the way I think of it is that teeth are part of the human body. Vision is part of our function as human beings. These are important parts of our health. dental care, is actually an area that is in particularly need of reform. It's one of the types of healthcare that's actually most restricted financially, that poorer people have the least access to. And that plays into socioeconomic disparities, that pays people with very bad dental hygiene can have difficulty finding jobs, and all sorts of other issues that actually exacerbate societal inequality. So I think dental coverage absolutely should be covered, and vision first for more or less the same reason. Let's jump around here a little bit. And again, if there's something you really want to see, you really want me to answer that I'm not getting to, you can tweet me at @awgaffney, and I'll continue to have a look at my notifications. So will this cover all pre-existing conditions is another question. And I think that's an easy question to answer, because that term will no longer be meaningful under a Medicare for All system. And why is that? Because it doesn't actually cover specific conditions. It covers all medically necessary care. So there won't be any type of conditions that's excluded. The care will be comprehensive, as I mentioned, and really no diseases are even mentioned in the bill, because it is basically irrelevant to this sort of system. That being said, the long-term care being left out to some extent of the Sanders bill, and we'll get to that more, I think, in a later question, is a weakness that you could say really is an area for improvement. And actually, that's the very next question I have on my list, which is, I'm going to read it out loud. Quote, unlike HR 676, Sanders' bill is not a universal system and does not cover all medically necessary services, because even after full implementation, all those who do not meet Medicaid eligibility requirements will have no coverage for the long-term care they need. So let's dive into this. So what exactly does the Sanders bill do in terms of long-term care? So as I mentioned, it would essentially cover everything under the Medicare for All system, but it would relegate long-term care to the states through Medicaid. So Medicaid would basically just be long-term care. Now, why does that matter? And why is that, who cares? One might say, well, who cares if it's being provided by Medicaid or by Medicare for All? Either way, long-term care will remain a benefit. The reason why it's better for it to be covered by Medicare for All itself is that Medicaid is different. Medicaid has eligibility requirements in which you have to sort of basically spend down all of your assets into poverty before it kicks in many cases for long-term care purposes. So in this system, long-term care wouldn't really be a universal benefit. It would remain most likely a means-tested benefit provided by the state Medicaid programs, available today, not merely on the basis of medical needs, but to some extent on the basis of economic means. And so I think many people feel that this is a real area for improvement. It is true that long-term care is extremely expensive, but PNHP proposals have always been very explicit that long-term care is care, and real universal health care means long-term care is included. So that is certainly my take on this, and I think that that is the take of many, if not most, if not nearly all people in PNHP. Okay, let's see. Let's go to another question here. That's a little different. Okay, so I'm going to read another question. So the question goes, my understanding is that prescription drug cost sharing in the bill is to promote the use of generic drugs. This seems useful. It would be good if prescribing physicians did not push brand name drugs over generics with the same effect. Is there cost sharing that is problematic, or maybe not problematic? Might have been the intent there. So let me restate what it is that the Sanders bill does with respect to cost sharing. So again, no cost sharing for anything with the exception of prescription drugs. To be clear, the bill says that this is done for the purpose of incentivizing the prescription of generic drugs, as this participant mentions. It also says that preventive drugs will not have copayments, and it also says that there's a cap on how much the copayments can add up to in a given year for a given individual, and that cap is $200. You wouldn't have to spend more than $200 a year on drug co-payments. So first, why do we not want co-payments on drugs? And then I'll get to the question itself. Many studies have shown that you add co-payments to drugs, people don't fill prescriptions. So you actually can do real harm. There was actually a study, a randomized trial that was once done, published in the New England Journal, that showed that getting rid of co-payments on sort of drugs for cardiovascular disease could actually even have medical benefit. So that is why we, in the physician's proposal, for instance, it's clearly stated that there shouldn't be co-payments for any sorts of care, including pharmaceuticals. That being said, I think this question is a good one because, we do need drug spending is out of control. We do need to do something about it. And it is true, if there is a generic drug available that is equally efficacious, that is equally safe, has a brand name drug and costs a fraction of the price, it's really just throwing money out the window to cover the brand name drug. And if there's pharmaceutical reps that are pushing these brand name drugs and physicians that are prescribing them, we're really talking about throwing away money. So I can understand where the impetus for this sort of provision came from. That being said, there are alternatives to cost sharing. First off, you could, in fact, say that co-payments only apply to drugs when there is a generic that is equally efficacious that's available, and in those situations, the co-payment would only be imposed if that other drug was available, and otherwise the generics have no co-payments. That would be one approach, but even that I think is sort of flawed because there's still going to be some of that waste going on for the reasons I said, the promotion of these drugs, advertising, that sort of thing. Possibility is just to use the formulary, the national formulary, to restrict access to the drugs that are the safest and the most efficacious and the least expensive. So you can imagine a system in which if there are two drugs that do exactly the same thing and one is less expensive, that the formulary only covers the less expensive one. And there may be specific circumstances in which the other drug is necessary, say an allergy, or maybe there's a very rare variant of this illness that it actually does make a difference for. And so exceptions can be made in those situations. Now, I will say that Sanders' bill does include a national formulary. It specifically outlines that, and it also outlines that it will be a system for the coverage of non-formulary drugs. So that there is an alternative to using cost sharing as the method of lowering drug costs. But this relates to another question that comes up right after that one. So this question, and I'm going to read the question, it says, one of the primary driving forces behind the high cost of pharmaceuticals in the U.S. is the U.S. patent system. A number of years ago, there was some discussion about removing pharmaceuticals from the patent system and exploring alternative incentives for innovation in healthcare. Are there any discussions on that today? And that's exactly correct. I think it was two national meetings ago, the board of PNHP decided that we would, come up with a proposal explicitly dealing with pharmaceuticals and going beyond what we'd always said, which was we need drug negotiations. Now, we do need drug negotiations. There's no question about it, which Sanders' bill and Conyers' bill both do. But clearly, we need to move beyond that. It's just not enough. There's so much, dishonesty in the pharmaceutical industry. There is, as this question points out, there are problems with patents being extended for trivial modifications of drugs, new coating on a pill, new delivery device, and many other problems with the patent system as well, which is that it doesn't necessarily encourage focusing research and development on innovative drugs that are actually going to make a difference in health. It may just be that people want to pursue a Me Too drug, a drug that operates similarly to an existing drug, because it's easier to do and you can get a patent on it and you promote it and make a lot of money off of it. So the current system of pharmaceuticals is failing. And so I think this takes us a little bit away from Sanders' single payer bill, because this is really a whole separate policy. I mean, it's related, but it's another policy arena. And I will say that I'm involved with the proposal to reform the pharmaceutical system more generally, not just doing drug negotiations, but doing, for instance, more publicly funded R&D that would keep more drugs in the public sphere without patent protection. Ways to make clinical trials publicly funded and therefore less controlled by pharmaceutical industry that has a vested interest in their outcome. So there's a huge host of reforms that we need in the pharmaceutical system that we have in this country, and that really takes us, I think, beyond the confines of Medicare for All alone. So I think it's great questions, and I think it's something we need to continue to talk about. And it's actually something that Sanders has been involved with as well, a separate bill. But for the most part, this bill does really focus instead on controlling pharmaceutical costs through a formulary and through drug negotiations. But I think it's clear we do need to go beyond that eventually. All right, more questions. So here's one. How will the Medicare for All bill affect current Medicare recipients? So I think, and this kind of brings us to another aspect of the Sanders bill. So one thing, and I didn't mention this up at the top of the hour, and I should have. One other big difference between the Sanders bill and the Conyers bill is the implementation period. The Conyers bill would actually implement the single payer system in the space of 1 year. So very quickly, some people think that's over hasty. That being said, that's, Medicare itself was implemented in the course of a year. From 1965 to 1966, about 99% of the nation's seniors were enrolled in the universal part of the program. So it is certainly doable. And Taiwan's, which was implemented in the early 1990s, likewise went into effect quite rapidly. So it certainly can be done. And again, the National Health Service in Britain passed in 1946, implemented in 1948. And that involved the nationalization of hospitals as well. So it went beyond single payer insurance. So this is a long-winded way of saying that the Sanders bill would affect Medicare recipients in a couple of different ways, depending upon whether we're talking about the transitional period or under the Medicare for All system itself. So the Sanders bill has a longer transitional period. Its period would last 4 years. And during that transitional period, a number of things would happen. First, there would be a Medicare buy-in. This would initially be available to people age 55 and older, and then the following year, 45 and older, and then 35 and older, until everyone was enrolled in the 4th year following passage of the legislation. And there would also be a public option that became available for the transitional period that would be available on the Affordable Care Act's exchanges. So during this transitional period of these 4 years, there would be a Medicare buy-in and a public option, both available. And the third thing that would happen during those transitional years would be that the benefits of those on Medicare would be broadened. And specifically, they would, current Medicare recipients for those 4 years would have coverage of dental, vision, and audiology services, and would have reduced out-of-pocket costs. So it would improve people's Medicare coverage for those 4 years. Subsequently, they would be part of the current Medicare participants would be part of the Medicare For All Act after 4 years. And when that happens, they would have the same benefits as everybody else. They would have no cost sharing except for prescription drugs, and they would have comprehensive benefits. So it would be fair to say that current Medicare recipients would have their coverage substantially improved by the Medicare For All Act, both during the transitional period and subsequent to that during the Medicare For All period. They would get rid of the copayments and deductibles, and everybody would be part of the universal system, so that would mean there wouldn't be networks. And that, is essentially, there's another question that asks the same question, which I think I got to, which is that points out that currently traditional Medicare is far from first dollar, meaning there are a lot of copayments and deductibles. Would the new plan be first dollar for everyone? And as I mentioned, it would be. After those 4 years, for everybody, there would be no cost sharing except for the $200 of copayments on prescription drugs. All right, next question. And this is a good question, I think. The question is, how will this bill help those who have Medicaid? And I think this is a good question because it speaks to the fact that what we're trying to accomplish with Medicare for All is very different than what people are trying to accomplish with many other sorts of incremental programs. Because under universal Medicare, we're really aiming to improve everybody's health care. Just about everybody's. We're not aiming to only cover the uninsured, which is critical, and I think we all really care about that. And that's one of the injustice of uninsurance is one of the things that pulls us into the advocacy of single payer. But it's not just about that. It's also about those who have insurance and who have high cost sharing, or are subjected to all these other injustices that harm their health and harm their financial well-being, and that make for a less egalitarian society. So when I speak about Medicare for All, I always emphasize the manner in which it will affect all groups. So this question, and we spoke about how it would affect people who have Medicare, and this question asks, how would it help those who have Medicaid? And this is how I'd answer that question. Medicaid is a very good program in so many ways. Passed the same year as Medicare, it covers people of low income. Traditionally, people had to belong to certain categories, disabled or parents of dependent children. But under the Affordable Care Act, it was expanded theoretically to everyone, making up to 138% of the federal poverty level. Although, as we know, 19 states were able to not expand their Medicaid programs because of a Supreme Court case. Anyway, so that is Medicaid. And what are the good things about Medicaid? Medicaid is pretty comprehensive benefits, and it has minimal copayments, cost sharing, in some cases none. And so those are some of its strengths. The downside of Medicaid is that it has sometimes functioned, and this is not true everywhere, but it sometimes functions as something of a second-tier system, in that it pays providers much less than Medicare, much less than private insurance, meaning that not all providers accept Medicaid. Studies have shown, longer waiting times for people with Medicaid to get to see a specialist in some instances, that's a real problem. It's not real equity, even if it's an enormously good program that has done great good since it was implemented. So what people with Medicaid would gain access to through Medicare for All is equity. They would have access to all the doctors and all the hospitals, just like everybody else. They wouldn't lose their comprehensive benefits, and they wouldn't lose their minimal cost sharing. If anything, that would stay the same, or the nominal copays that they have now would go away. So again, I think that it's pretty clear what each group who are currently insured now would gain through Medicare for All. Those on Medicare would lose their copays, deductibles, and would lose their insurance networks, whereas those with Medicaid would gain more equitable access to doctors and physicians without networks that sort of confine them to sometimes a second tier of access. So, good question. Okay, I have a question coming in from Twitter now that goes back to the issue of pharmaceuticals. And the question is, does Sanders' bill regulate prescription drug advertising? And so, again, this goes back to my earlier statement, which was that this is really not a pharmaceutical reform bill. This is a single-payer bill. And so it does require negotiations to bring down drug costs, and it does provide access to prescription drugs, but it doesn't do things like that, which I agree with Dr. Bill Honigman, who asked this question, that we need to do something about drug advertising. It's an enormous waste of money. It's sucks money out of the system and it misleads people, but it's not really what this bill is about. We need a separate we need to just think about that probably as a separate piece of legislation. All right, we are covering a lot of ground. I hope I haven't lost all of you yet, but for those of you who are still on the call, let's go to something a little bit different. So there's a question here about how the VA medical system would fit in with single payer, and there's a second question, second person who asks that as well. So let me read one of those two questions. I agree. Well, I'm going to skip the beginning part of it. The note that unlike Sanders' current bill, even if the full implementation, is never going to be a single-payer system and will not bring savings of a true single-payer system, because even after the 4-year rollout, it will still have multiple payers, VA and the Indian Health Service. It also notes that Medicaid uses for-profit providers, thereby keeping the unnecessary additional costs of profit motive in our healthcare system. So there's really two different questions wrapped up in there. The first is, what about the VA and the Indian Health Service? And I think that is a fair question. So basically, what about them? So in the Sanders bill, although there would be no private insurance, effectively, the Veterans Administration and the Indian Health Service would continue. And that is actually not exactly the same as the Conyers bill. In the Conyers bill, the Indian Health Service would be integrated after, I believe, 5 years after the law is passed, and then the VA, there would be some sort of evaluation of whether what should be done with the VA. Now, I think this is not an easy situation in that I think we do need to take into account what veterans want and what Native Americans want in deciding whether or not those programs should be integrated. And I would push back against the question, actually, that this is not going to be single payer because we still have more than one payer for the following reasons. The VA and the IHS would really be carved out, separate from the overall system. So the problem with having hospitals can't just be paid a global budget, let's say, or doctors can't just deal with one single insurer. They need to deal with Aetna, they need to deal with Medicare and Medicaid, and it creates huge to deal with insurance companies. And that or everybody. Having the VA, because the VA would be separate. In other words, it's, your hospital would be charging the Medicare for All bill, but then also be dealing with the VA. The VA would be a provider. It's a fully socialized system, separate from the overall system. So, I understand the point, but I think that we wouldn't really lose much in terms of administrative efficiency or savings by having the VA. And I think that overall, whether the VA or the IHS are integrated into the system should really depend upon the feelings, the viewpoints of people who currently rely on those systems. Especially, Native Americans are obviously a highly marginalized group, and they really should, it should be really their views on this that are paramount. All right. Let's move onward. And then the second part of this question points out that Medicaid uses for profits, but that actually everyone uses for. So all the insurers currently cover care provided by for-profit providers, meaning for-profit hospitals, for-profit dialysis chains. And I already spoke about how the Sanders bill does not exclude those providers and how that's an area of improvement for this bill. Okay, let's choose another question. This is an easy question to ask, and it comes up a lot, and I think it's important to at least briefly deal with it. The question is, are there provisions for retraining those currently employed in the health insurance industry? The answer is yes. And I will say the Sanders bill does this slightly differently than the Conyers bill. And I'm not really sure which is, better or which is more adequate. But essentially, the Sanders bill sets aside as much as 1% of the total health budget of the Medicare for All system for 5 years for the purpose of taking care of displaced workers from the insurance industry and related administrative areas. So 1% of the health spending would go for 5 years to take care of those workers, which is important because, it is not workers' fault. It's not people's fault that they happen to work for these industries that are not really providing a service to the country. And so it's important that we do something and don't simply pull the rug out from under them. Also sets aside money for that in a different fashion. I think it is that the salaries will be guaranteed for up to, I think, 2 years, I believe. And during that period, they can have their salary sort of compensated and then be prioritized retraining. So I think both are reasonable approaches. I don't know if one is necessarily better than the other. All right, this is a question that has come up and, sort of a point of controversy. So let me read it. I am concerned that if providers, especially specialists in demand, are not allowed to participate in both the national system, and I think it says are allowed to participate in both the national system and a parallel private system, which most countries have, there will be a shortage of providers participating, pros and cons. So I may have mangled that a little bit, but just to boil it down, the question comes down to this. In the Sanders bill, and I suppose in Conyers bill as well, doctors could totally opt out from participating. They could say, I'm not going to treat anyone through Medicare for All, who's on Medicare for All, or bill Medicare for All. And I will say the Sanders bill includes a number of safeguards to make sure docs aren't, being paid by Medicare for All while also charging the patient. That would be illegal. It includes other sort of safeguards to ensure that docs who are out are totally out and not trying to have it both ways. And at the same time, I did mention that private insurance would be excluded. So really this comes down to the fact that, what happens when some doctors decide not to participate and sort of, let's say, treat the wealthy in sort of a parallel system. So, I think at the end of the day, the best situation would be one in which we all were treated in a single pool and, at a single tier of care within a universal system that had an extremely high quality and that we could all rely on and trust. And I think that's what we all want. But I do think that as much as that's sort of the gold standard, I'm not so sure that it's easy or possible to make it illegal for providers to not participate. And there are very few countries that actually do that. Even Canada, that has some of the stiffest restrictions on private practice of medicine anywhere. Depending on the province, doctors can often, if they are completely separate from the system, from what Canadian Medicare as it's called, can do some amount of private care. Maybe Cuba, that's not a possibility, but really in most of the world, it's not possible. Countries do not make it illegal for doctors to practice private medicine as long as they're outside of the public system. So again, I think there's, sort of what we envision in a sort of utopian sense, but kind of the reality and also the politics of sort of making that illegal, let's say. But it's an interesting point, and it's worth talking about and thinking about how we can avoid private system flourishing, or sort of displacing the public system anyway. A couple of ways you can do it, I think. One was in the physician's proposal, the PNHP's physician's proposal, but that's not in either the Sanders or Conyers bill, and that's to actually fully subsidize the education of healthcare workers and professionals who participate in the Medicare for All system. So that is a strong incentive to make sure that docs are not opting out, that the cost of their education was subsidized, by the Medicare for All, that would mean they would have to participate in the Medicare for All system. And so I think that could go a long way to ensuring that the private parallel system, if it exists, is marginal and doesn't sort of chip away at solidarity, universality, all the things that we care about in a public healthcare system. Quick question here from Twitter: is there provision for fraud, excessive use, and abuse of system? There is, in fact, a short provision on fraud, and it's more or less just replicated from the current existing Medicare guidelines on fraud. That's in the Sanders bill. I don't believe there's a provision on that for Conyers. I think the question of excessive use, though, is an interesting one, and it's something we're going to have to grapple with. There's no easy answer to excessive use. The use or overuse is driven by a lot of factors, only one of which is, fee-for-service medicine, in which providers are incentivized to provide more care. And so I think that, as wonderful a thing as single payer is, and as enormous a step forward as it would be to achieve it, it's not going to fix everything about our healthcare system. So I think it's important to keep in the back of our minds. Okay, let's look at some other questions here. So here's a question. So now this new sort of category of questions verges a little bit away from some of the policy issues and kind of heads more into the politics and to the activism side of this. So this one says, what can we do as individuals? What can we as individuals do to increase the chances of successful passage of this bill? So, I think we can all do something very different. I think it depends upon where we are, who we are, what we do, and what we like to do. So I think in PNHP, for instance, we've often taken the physicians part of that acronym seriously and tried to really spread the word among our colleagues to make sure that as the political window for single payer opens, that physicians will be on board and they'll be comfortable and they'll be excited to take part in this system, because we can't enact this if docs are opposed, and we wouldn't want to because it wouldn't work well. So I think whether we speak to colleagues, whether we do grand rounds, or whether we do presentations, or whether we go to meetings, or whether we get people to go to meetings with us, or whether we just discuss the issue with people and get them to join PNHP, I think those are all useful ways of spreading the word among physicians. And then in terms of how we do it as a society at large, obviously we need to push senators, we need to push representatives, we need to form coalitions with other groups. It's really too big a question to answer now, but I think it's something we have to really think about, particularly as single payer moves more and more into the mainstream, and as the potential to actually achieve it elevates. And so I think it's a good question. All right, let's move onward. I think there's a question here that I think is useful. So how much of the eventual savings of the Sanders bill will not be realized during the 4-year transition, where providers and payers will both have to maintain the administrative structures of our current multi-payer system? If we don't point this out, our opponents surely will use it to destroy the plan before full implementation. I think this is a fair point. I think that, again, during this 4-year transition period in the Sanders bill, as I mentioned, there will be a Medicare buy-in, there will be a new public option, and there will be increased benefits for Medicare beneficiaries. Now, those are all good things in many ways. So those are all things that will expand access to care. However, that really does mean spending money and not achieving cost savings. So it really means that the spending will go up and the savings won't go up so much in the short term. And that's one disadvantage of a 4-year transition. So I do think that this is another reason to push for a shorter transition period, because as this question points out, it's going to be politically sticky when during those 4 years we're spending a lot of money and not getting all the savings from administrative savings or drug savings. That being said, I think the transition period issue isn't really one as much about deep principle that I think we need to make a matter of life or death, or the black and white. It is more an issue of what politics and the best way to implement something. And I think it's an issue that we could continue to discuss, and that maybe we could push for a shorter transition period. Okay. This is a quick one I can answer. Am I correct that the healthcare dollars sucking Medicare Advantage will be an option only during the transition? So Medicare Advantage plans are privatized Medicare plans that seniors can buy into. They have some benefits over traditional Medicare, like lower cost sharing, but they also have smaller networks. But as the question points out, they have functioned essentially as a siphon of taxpayer dollars from the Medicare system into the coffers of the insurance industry. And really, they don't provide any benefit to our healthcare system at large. So the answer is yes. Medicare Advantage would continue to be available during the 4-year transition period, but it would disappear, as it should, under the Medicare for All period, which begins after year 4. And I think that's necessary because we know from this sort of history of Medicare Advantage that the private insurers will use all the tactics up their sleeve to cherry pick the best risks, to play games with coding to maximize revenue, and they really can't be trusted to run our healthcare system at the end of the day. Here's another question. Are there any specific strategies to address health disparities and to promote health equity? And there is. The bill actually explicitly sets aside, discusses how the Secretary of Health will have to make it a priority to study and to evaluate the functioning of the system from the perspective of health equity and disparities, along the lines of race and gender and economics and so forth. So I think that's an interesting aspect of this bill. I think also it's important to remember how important single payer is in and of itself from the perspective of equity. I mean, nobody thinks that single payer will get rid of healthcare inequalities of race or eliminate healthcare inequalities when it comes to things like transgender care. But I think that it would make a huge and important step in that direction by providing a single tier of care available to all on an equal playing field, and by eliminating financial barriers to care, and by achieving, at long last, universal coverage. There's a question here. I'm kind of bouncing around, but it's a question here. What will the psychiatric coverage be? And the bill, in some respects, doesn't go into great detail on many of these questions. It explicitly includes mental health care in this Medicare for All system, but it does not, for instance, discuss how exactly that would work. To be covered. That being said, it doesn't speak about how any specific area of care will be covered. And so these are the sort of nitty-gritty issues, I think, that will be worked out, will have to be worked out, and that we can't expect a bill like this to sort of lay out all of the specific policy details ahead of time. All right, we have not too much time left. Why don't we pivot briefly to the issue of financing? So I'll read a question now. What is the best yearly cost estimate for the plan? Senator Sanders states his proposal will cost $1.4 trillion per year, while some others estimate $3.2 trillion per year. Do you agree that even the higher estimate will be less costly than staying with the current healthcare system? So I think that there are ways to answer this question. So first off, it's very important, because this is going to be a tricky sort of issue moving forward. It's very important that we speak separately about public spending, new public spending versus new national health spending. So the $3.2 trillion figure refers to the total healthcare spending of the United States, public, private, everything. Of that $3.2 trillion, about a little more than $2 trillion or 65%, is already being spent through public programs. Okay, so Medicare, Medicaid, various tax inclusions, and so forth. So, even if total U.S. national health spending stays the same, new public spending will equal the difference between those two numbers. And Sanders has put out a white paper sort of going through some of the different ways of raising that difference. But the bill itself does not. The bill itself does not include a funding mechanism. It states that money currently being spent on Medicare and Medicare will go into the Medicare For All system, which we talk about, but it doesn't include explicit taxes. And Sanders has answered this, and he basically has said that he needs an economic analysis, that he wants this sort of done in sort of a careful and deliberate fashion, that this is sort of a work in progress. And so I think it's a fair point. I think that how we explicitly choose to fund the system is an important issue, but it's a slightly different question than how the system is structured. And so his white paper describes a number of potential taxes and how they could raise money over time. And it's things like a sort of a premium that's paid by employers, if you want to call it that, really more of a payroll tax. It includes things like raising personal income tax on the rich, creating new taxes on capital gains and dividends, making, in other words, the taxes on wealth be similar to taxes on work, and a number of other possibilities. This is something that's going to need to happen, and I think we're going to see some, economic analyses that put forth projections of costs and of how we can cover those costs. But again, that's a different question than national health spending. And it's a different question than how will individuals be affected. I think it's very fair to say that even were total national health spending to stay the same, the majority of people would get a better deal, assuming the system is funded progressively. Maybe some of the rich will pay more, many of the working class will pay less, and many people who currently pay very little will continue to pay very little. Again, every time someone mentions new taxes, we need to be talking about the end of premiums, the end of cost sharing, the end of co-payments. So it will be interesting to see what sort of a financing plan they come up with. But again, there's different ways to fund it, and the key point is that we can definitely afford single payer. We know this because other countries do it. We also know this because there's estimates on the kinds of savings you could get out of transition to a single payer. As I mentioned earlier, I think administrative savings are estimated at greater than $500 billion a year. Pharmaceutical drug cost reductions might save more than $100 billion a year. So those kinds of savings could cover the new costs of the system. And there are new costs. The new costs are going to be things like the cost of covering the underinsured, or the fact that some of us will use more health care because our deductibles were previously preventing us from using more health care, and now we're able to get the care we need because we have better coverage. And at the very least, I think that the savings that single payer produces would certainly cover those new costs. Now, even if that happens, and let's say even if the savings left over, we're still going to need to replace a lot of the private spending on health insurance premiums with taxes. So we should be clear about this, that there will be new taxes that will have to be implemented in order to cover the costs of the new system and to replace current existing private expenditures. But for most people, those new taxes will be lower than what they're currently spending, and they're very wealthy. But then again, we want to reduce economic inequality as well. And maybe, we can do this sort of two birds with one stone. But again, we don't have an economic analysis yet. So we can't sort of say to people, this is what you'd pay under standard single pay, standard bill. This is what you're currently paying, and here's the difference. It is 9:59, and again, that is a very full hour. Is a long time to hear me go on and on about all of these detailed issues. But whoever took time out to hear me, thank you so much. And I really mean it. I think there's a lot of discussion we're going to be having in the coming months and coming years about this. This isn't the end of the discussion. The Sanders bill is not the end of the discussion. It is a very exciting moment, however. This is a big step forward for the movement. This is a big step forward for the country. This represents a real turning of the tide in the single-payer community. And it's great to be excited about it. And we should be enthusiastic about these bills, and we should welcome them as a major step forward. While we're doing that, we can talk about some of the ways in which the bills can be improved. And I think that's an important role of PNHP, and it doesn't detract from the energy of the moment. It doesn't detract from the movement as a whole. It just means, look, we're here to do what we can to be accurate, to make these bills the best they can be. And in fact, improving the bills is going to, if anything, improve their chances of passage, not lower them. So I think we should combine enthusiasm with collegial, camaraderie critique, and I think with that approach we can win this battle. But again, thank you so much for listening to me today, and have a wonderful evening.